introduce yourself.
Okay. It's a pleasure to introduce myself. I'm happy to be here today. I am Emanuela Locati. I'm from Milan, Italy. I am also been involved in the Society of International Society of Water Monitoring since many years, in fact. And my main interest is non-invasive electrophysiology. And I have been working with Arthur Moss and then Philippe Coumel, so I have a quite long experience. Yes. And now I am working with Carlo Papone in Milan, and I am working in both electrocardiology, collaborating with Peter Van Dam and other engineers from the Polytechnic of Milan, including Enrico Caiani. And also I am involved in cardiogenetics. So our main interest is in Brugada syndrome, long QT syndrome, cardiomyopathies. So that's all. Please.
Thank you, Gary. Just to explain, we started this brief introduction while waiting for you. So now you're in the session.
Great. Yeah, so it's great for everyone to be here. Thanks so much for joining us on the weekend. You've heard from Emanuela. My name's Gary Tse. I'm the co-chair for this session. I'm currently based in the UK at the Kent and Medway Medical School. Our research is focused on angiopathies, and we also do some work on cardiovascular epidemiology. So if there are any opportunities for collaborations, please do get in touch, and we'll be very happy to do joint studies together. So without further ado, our first speaker is going to be Dr. Deepak Padmanabhan from India. The presentation title is What Do Machine Learning Algorithms Offer in Sudden Cardiac Death? So please, Dr. Deepak.
Perfect. Thank you. Thank you for the opportunity to present before an August audience on something that I'm very passionate about, both AI based off ECGs and their applications in sudden cardiac arrest. Do stop me if I'm going over time. It's something that I could speak for hours together. Just don't want to bore everybody off. Ooh. Did you just lose me? Okay. So I hope you can see my screen. The objectives of our talk here are going to be mainly to discuss the scope of the problem, namely sudden cardiac arrest in very brief amounts, the challenges that we face while managing or trying to even get to patients of sudden cardiac arrest, and the role of the artificial intelligence machine learning algorithms in the recognition of sudden cardiac arrest, the prevention of the same, and optimizing resources when dealing with it, and some amount of implementation attempts that have happened in recent times in the real world. So the problem statement, and especially just want to take some studies out of India, are the fact that 10.3% of all deaths presenting to 8 medical colleges in an urban area were adjudicated to be secondary to sudden cardiac arrest. These ages were 5 to 8. These deaths were 5 to 8 years younger compared to populations as reported in the Western Hemisphere. In another major center in the country, out of hospital cardiac arrests, you had just 7.4% of them receiving bystander resuscitation, resulting in a survival to hospital of just 30% of these patients, and survival to discharge was even more dismal, nearly 10%. So the reasons for poor survival in our woods, our side of the woods, is that there was an inadequate initial response from people surrounding. The response times of medical personnel were extraordinarily long, and there was a poor profile of patients over the years as we get older and as we live longer. So coming to how machine learning can actually help or kind of ensure that we do better is where we all start, trying to prevent it or trying to diagnose it much earlier. A lot of us who kind of work in the field are very, they know of this algorithm that was famously published in Nature in 2019, where on the basis of an ejection fraction, on the basis of an ECG, a single 12-lead ECG, you were able to classify people as having normal ejection fraction or low ejection fraction. This is a revolutionary algorithm that was designed by the Mayo Clinic, where they were actually able to not only diagnose these people off of routine ECGs, but were in some ways even predictive of a lower ejection fraction across a span of time. So if you had a false positive reading of the algorithm, you stood a chance that you would be able to have that particular ejection fraction in years to come. If you compare it with the area under the curve for other routine tests like the TMT and the pap smear, the AUC for this particular algorithm was close to 93, which is incredible. So using that to kind of think about applications for the same, not for the ejection fraction, but for other similar conditions that could cause sudden cardiac arrest, another algorithm based on similar principles was created for hypertrophic cardiomyopathy, which did have a very high specificity when the age was less than 40 years. So again, early diagnosis. In addition to that, it also was able to discern a reduction in the possibility of hypertrophic cardiomyopathy, especially when some interventions were done. So giving us the idea that, look, there could be a potential scalable screening tool that could help you identify patients at risk and therefore participate in the principle of primary prevention. Going ahead from there, you could also use data sets to get NLP or natural language processing techniques to automatically extract risk factors in hypertrophic cardiomyopathy patients in order to be able to pull out these patients better and understand that these could be problematic. You could also look at MRI reports containing positive diagnosis of hypertrophic cardiomyopathy. And this all stems from the ability to use algorithms pertaining to NLPs. There's another very interesting trial that was conducted using cellular phones. This falls into the ambit of how can you diagnose or reach these patients earlier. Using the ubiquitous mobile phone or the smartphone that's present across various brands, a particular study was able to discern stertorous breathing or breathing just prior to a sudden cardiac arrest and alert an emergency response team. When applying individual frequency filters, it actually had a false positive rate that was non-existent. So this again, early diagnosis being facilitated by potential use of machine learning algorithms. Another recent example of finding out populations at risk were the automated or the the machine learning driven calculation of the QT interval, which was, as you can see on the Bland-Altman plot, pretty much similar to what a cardiologist would have calculated. In addition to that, it was also able to figure out whether a patient in a very selected population, however, as I must say, the ability to discern the presence of a genotype positive LQT patient compared to someone who was not genotype positive, even when the ECG was having a normal QT. Again, the principles of prevention and identification of people at risk applied to the challenge of sudden cardiac arrest. Going on from there, if you go on to this study by Nakashima et al., you were able to document using AI the ability to deploy resources to areas which were potentially at higher risk of having more sudden cardiac arrests depending on the time of the year. So across data sets which were training and testing, you were able to get significant correlations. Similarly, with the CAR-T algorithm, there was a trial that was conducted in Europe where the ML alerts on dispatcher recognitions for OHCAs during calls to emergency medical services. The algorithm did quite well. Unfortunately, the dispatchers would not trust the algorithm enough, resulting in non-significance of the trial itself, which brings us to the most important thing when creating these algorithms. Do we as humans actually trust them? This is currently going on where ambulance triaging is being used with this algorithm. So the key aspect beyond what is prevention and beyond early identification is the ability to optimize resources. There have been machine learning models that has been created for survival and neurological outcome prediction for OHCA patients, and also RRT teams within the hospital to reduce in-hospital cardiac arrests. The DEWS system for figuring out what is a patient who will require additional care has been tweaked with the help of single or two additional parameters which have been evaluated by ML algorithms to cause increased detection, but at a much lower alarms per patient per hour, thereby allowing us to deploy our resources better. Similarly, prediction of cardiac arrest in purely hospitalized patients using single lead or 6-lead ECGs have also been attempted. Now, going on from the allocation of resources and better utilization of them to choosing patients better who would do well with current existing technology for improving heart failure and sudden cardiac arrest and death regarding them, is the use of machine learning of QRS waveforms among two groups of total of 946 patients undergoing CRT. When the machine learning algorithm was used, survival free from death, LVAD, or heart transplant was being able to be chosen better by these algorithms. So in short, you were able to choose those patients better who would respond to a CRT and those who may not, giving you this so-called CRT response score, which has got tremendous potential in the future to judge which patients will be non-responders and perhaps be better used and be better served by going on to replacement therapies. Now, in this interesting study, which was conducted at the Stanford Institute, Rogers et al. Took his patients with ischemic cardiomyopathy. They recorded MAPs during an invasive evaluation and then followed them up and predicted clinical outcomes. They then used machine learning to look at the patients who did have VTVF or who did have mortality and who didn't, and then compare their action potential phenotypes to create action potential phenotypes by computational models, and thereby use certain characteristics of the action potential or the MAP, membrane action potential, to discern which patient may or may not be at risk for sudden cardiac arrest. So thereby giving us a potential to get a personalized cellular mechanism to predict sudden cardiac arrest. But while we go into all of this and seems magical, it's critical that we are able to assess AI literature well, especially data. The quality of data gives you the quality of outputs. And also data may not be similar across geographical populations. We do need to validate all these models across external populations and update them over a period of time. The oversight by both insurance companies and by regulatory bodies are required, and there is a guideline for clinical trial protocols as given by the Spirit AI Extension Group. We also need to choose the correct patients to be included in the training data set and for validation of the algorithm. If you use a data set or a cohort of patients who've not been included in the original algorithm or whose clinical features at least do not correspond with the training data set, the values or the outcomes may not be very similar. We do also need to tweak our hardware and our software to be compatible with outputs given by these algorithms. The hardware is increasingly becoming more frequent, and it includes various wearable implanted cardiac devices, AI-enabled stethoscopes, and mobile single-lead and multi-lead ECGs. It also brings us to an interface whereby a single ECG can actually give you various AUCs for a variety of different conditions, so as to be compared to a simple drop of blood. Going on from there, as I mentioned very briefly earlier, having an AI algorithm and trusting AI algorithms for making decisions are two entirely different things. It does require a great deal of training, understanding, both on the part of researchers and on the part of physicians during their training for this to happen. The mind being a high resistance pathway that it is, rationality poorly describes behavior change, and in fact, the most powerful incentives turn out to be social. So by the time these things happen, we are all dealing with crowds, we are all dealing with highly congested and overworked healthcare systems. So the solution definitely still remains in bystander CPR, and that is what is very critical right now for all of us. So in summary, sudden cardiac arrest remains a challenge of immense magnitude. Artificial intelligence and machine learning algorithms can aid in early detection and detection of at-risk group. It helps us allocate resources wisely and possibly predict in-hospital cardiac arrests. Acceptability of these algorithms remain a challenge, and therefore bystander CPR and widespread awareness of the same still remains a viable and important intervention. Thank you for your patient hearing. I would love to discuss it at some point in time.
Thank you, Deepak, for this wonderful presentation. Really, a lot of information and very, very, I would say, inspiring.
Thank you.
Truly. I don't know where to start because there were so many ideas into that. So I think that one of the main points, in my opinion, is the choice of the population, the training population and the testing population, of course. And I saw this as a truly major issue. So I would like to hear further comment on this problem.
Let me kind of begin by giving an example. Because the ECG AI algorithm, prediction of the low ejection fraction using 12-lead ECG, was one of the earliest algorithms to come out there. There has been extensive research after the initial publication to see how it works. It's been trained in various racial populations. It's been trained in various subsets of people. It's been trained in across countries, and it's been trained across hardware. I mean, the form factor on which these algorithms were created, they need to be verified at every step. So if you're using it on an AliveCore-like device, which is a single-lead ECG or a 6-lead ECG, the algorithm may perform differently. If you're using it in India with an AliveCore, it may perform differently. If you're using it on a digital stethoscope, which is capable of actually recording a single-lead ECG, it may perform differently. So validation and ensuring that accuracy is retained across various populations and across various form factors remains a responsibility of all of us who participate in such research. And I think only then can we actually be allowed to depend on them for aiding us in caring for our patients.
Yeah. Yes, I think that beside the choice of the tool, of course, is also the choice of the population, which is sometimes very difficult. So we have been working, for example, trying to extract Brugada information, which is, I think, a very, very important issue. And in fact, it was very difficult to decide what kind of patient or the subject, because there is a very, very important confusing effect of age, for example, gender, and also race. So I think it is very complicated, much more than we. Okay, the more you look into this, the more complicated it gets, in a sense. Yeah, because I think, for example, race is such a confusing, very complex factor. We knew that since many years, but we have never really dealt with that.
Correct.
I have only, could I talk, or how it is organized? Thank you very much for this presentation. I will discuss one thing which interests me very strongly, and it is how to achieve the trust to the algorithms. Since I was working in computerized electrocardiography, as I told you, in 80s last century, so it is unbelievable how the resistance of the clinical environment, how it is strong. And when you were talking that validation is one of the strong tools, yes, absolutely, I agree, absolutely. The other one is the interpretation of the parameters which affect the final decision, and something like pathophysiological plausibility. And then the clinicians are somehow more keen to believe it. But anyway, it is interesting. It is psychologically very interesting.
Yeah.
Because it is like machines want to replace our human whatever. Yes. Thank you. It was very interesting.
Thank you. Thank you for having me on.
Great, thank you, Deepak and Emanuela. So I'm going to introduce the next speaker, which is Dr. Kamalan Jeevaratnam. So he's based at the University of Surrey in the United Kingdom. His presentation is going to be on, can we predict atrial fibrillation from the sinus ECG? Hi, Kamalan, please.
Hi, Gary. I'll just share my screen.
Yeah.
Hang on. Shut them all down. Can you all see? Oh, no.
Yes.
Can you all see my screen?
Yes, it's coming up.
Yes. Yes, we can see it.
Okay, brilliant. Okay. No. So thank you very much. I will. Sorry, I'm just going to put this in the slideshow. Okay, so thank you very much. What I will be talking to you all about is predictions of proximal AF from normal sinus rhythm, and explaining my own personal journey of taking this research idea from a One Health, One Medicine perspective, and where we are currently at the moment in terms of what we're doing and how we're progressing this. So we all know that proximal AF is a self-terminating condition. It lasts minutes to days and accounts for about 25 to 60% of diagnosed cases. And the risk of AF and sustained AF or PAF causing stroke-like incidences are very similar in patients, and therefore the impact these condition proximal AF has on healthcare services, on healthcare resources is significant, given that, you know, the ability for us to detect this condition, especially due to the proximal nature. There is clearly an unmet need to improve how we diagnose PAF, given the ability for us to detect current existing monitoring process. So continuous ECG monitoring by implantable devices have shown that, you know, it's really an underperforming approach with 30-day event recorded sensitivity. It's about 23%, and worse still for 24-hour Holter monitoring. So there is an opportunity gap that, you know, needs to be met, that you can, where algorithms and potentially machine learning approaches can play, if not to take it up to 100%, at least to increase it to an acceptable level of how we can then start early diagnosis and detection of this condition for more increased monitoring or enhanced monitoring of patients with proximal AF. So obviously the clinical question here is, how do we identify individuals who've had rhythm disturbances that only occur intermittently? And that's really the key question here. You know, it's not something that you can capture regularly and it occurs and comes and goes. So based on the fundamental knowledge of electrophysiology, we hypothesize, and I put horses here, and I'll come back to you why, who suffer from PAF also have a background electrical signal in their ECGs that are not discernible to the clinician's eye. So can we develop computational approaches to try to detect these hidden or these background-like signals by just looking at the sinus rhythm ECGs for patients or animals that have this condition, and then develop and validate this algorithm? Now, the reason I talk about horses is because what has come, as you mean, in the UK, the horse racing industry is worth annually £8 billion. And horses also suffer from proximal AF as well, and leading to potential sudden cardiac death during race. So the industry is very much how do I say, in tune to trying to prevent sudden cardiac death of high-performing athletes, in this case, high-performing racing horses. and how you can prevent that or detect that early. Because what you can do is that if you do detect horses with AF, you can pull them out of a race. And therefore prevent the incidents from occurring during race. So there's a lot of commonalities in terms of situations, and it leads to poor performance. Like in humans, it leads to poor quality of life, uneasiness, palpitation. There is risk of sudden cardiac death as well. It's elusive to diagnose, very similar in humans. And risk in humans, the risk increases with age, possibly due to atrial hypertrophy. We also know that in horses, in racing horses, that training-induced cardiac hypertrophy, specifically atrial hypertrophy, can increase the risk of AF development as well. So there are significant parallels to try to study this and to try to intervene in this. And that was one of the approach we decided to take, as to let's try to understand where we can start studying this. So what we did was that we had several computational approaches. Naturally, you'd be surprised or not so surprised to know that the research group, well, my research group got a lot of funding from the horse racing industry. So they had lots of money. They had a vested interest in trying to identify and find a solution to this problem. So they were prepared to invest money into the group and into this particular idea. So our natural progression was to start this research in equine athletes. Now, we looked at several different approaches. One was complexity analysis, where we looked at trying to understand how these analysis, whether it is applicable in the first instance to just normal ECG monitoring. Can we use complexity analysis and apply it on ECG? And yes, we can. And we showed, when we demonstrated the methodology in a publication, to show that we can apply this analysis on normal ECGs, and we demonstrated how this can be applied. We then went on to recruit cases and controls retrospectively, going back and recruiting cases and controls and trying to identify, can we actually use the algorithms that we originally proposed, which is complexity analysis, and can we then look and see what sort of predictive ability we have. And what we're getting were that we were able to demonstrate that by analyzing just normal sinus rhythm ECGs. So these are PAF horses, but not the ECGs were taken during their normal sinus rhythm episodes. Can we actually can the computational algorithms actually identify if this was a PAF horse? And we were trending at about an AUC of about between 90 to 95 in this particular study, which we went on to describe. We then ran a single blinded case control validation study on complexity analysis. What we were looking at is we're using two different methods of complexity. So you have the feature detection plus the Lampel-Zeev 76, and then you have the feature detection plus the Titchener method. These are all, I'm not going to get into the specific details of the the algorithms, but these are all mathematical scripts derived from different mathematical formulas that we apply and we automate within the system. So what we were getting at is that ideally a feature detection method was giving us an accuracy of about 0.98. And that was complexity. One of the questions that kept eluding us was the physiological basis for complexity analysis. And the truth is, we never really had a physiological basis of what complexity analysis is actually identifying on an ECG. So if you ask me today, what is it that the algorithm is identifying in the ECG that is causing it to detect the change? My answer is I don't know. So what we did then, we decided we should go and look at a different analytical approach, which will give us a bit of a physiological background. And we went to restitution analysis. So in restitution analysis, we are looking at the dependencies of the RR interval and the QT interval. So we have a physiological basis to see how this analysis works. So we applied this again onto equine ECG, and we looked at it and we said, you could apply this technique on equine ECG, work. We then went on to show how we could undertake this activity and demonstrated its ability from using a 3D. So using all three intervals, in this case, RR, QT, and TQ. So we use three dependable variables. we were able to identify using a majority vote approach. We were able to get an area under the curve about 0.9, and that allowed us to conclude that three-dimensional ECG restitution analysis can potentially be used as a metrics for automated method of screening of proximal AF. Now, these are all screening normal sinus rhythm ECGs. We've not screened any PAF traces. All we're doing is screening sinus rhythm ECGs from PAF horses and non-PAF horses. Okay. So what we've done more recently, is that we have now gone global, and we are running a multi-center trial across different places, different regions. We've got in the US, in Hong Kong, in Singapore, in Malaysia. These are all high active racing industries that have a vested interest. So at the moment, we've completed the first part of it, which was funded by the Engineering and Physical Sciences Research Council and PET Plan, which we've completed. We recently got funding from the US to determine if we can now use it not only for proximal AF, but also for complex ventricular rhythms. And then we have just received funding actually just this week from the Betting Levy Board to run a multi-center single-blinded field validation trial as well, to carry on to see how this. Now, all these is occurring in the realms of the racing athlete, i.e. the racing horse. But what it has led on to, which is the One Health approach, is more recent work about how there was a retrospective case control pilot study which was undertook using human ECG, and again looking at complexity analysis. And in this case, we were able to get an AUC of about 0.91 roughly in this percent, and again analyzing sinus rhythm ECGs. Now, there are plenty of limitations. I'm not going to lie, plenty of limitations to this study with the type of cohort that we had, the retrospective nature, the size, the sample size, when were the ECGs taken, confounding factors such as drugs as well that were being administered to the patients at the time of ECG recording for us to obtain the normal sinus rhythm. Those were all confounding factors, but we were lucky enough that we recently received additional funding from the Medical Research Council, where we are actually running the Predict AF study. And this is a identification study where we are prospectively recruiting participants across a range of GP practices in the Surrey region, as well as from the Liverpool Heart and Chest Hospital. And what we're doing is this is a case control design, and basically recruiting patients' sinus rhythm ECGs from various individuals with those who have a confirmed diagnosis of PAF and those who are controls. And this is the next step of the process that we're going, is trying to identify whether we can apply the algorithms that we have used previously clinically in racing horses, now trying to look and see whether we can further apply it and validate it in our human PAF cohort. What's interesting is that the basis for our Medical Research Council funding was the success of what we did in the equine clinical scene that convinced the Medical Research Council that they should be giving us money to carry this out in the human arena of research. So it was a very strange approach for us to take to come to this point, but demonstrated the One Health sort of one medicine approach as to how we can take a particular research idea through the different species. So the funders for all my work is listed here, and I'm very thankful to them, and also very thankful to all my collaborators across the various countries and regions, and also those here today, Gary, for example, who we work closely with. That's it. Thank you very much.
Thank you really for this very interesting presentation. In fact, it is very interesting also to see that you are applying this methodology also to horses beside human, and then that could be a very interesting model. Actually, we can think of other species where it would be very interesting. For example, dogs, we know that dogs have very different profile than humans, also in terms of sympatovagal profile, for example. That also in relation to sudden death.
Yes.
Yeah, no, very true. I mean, I think Gary would know this, is that we've been trying to secure funding from the Medical Research Council and and they were all, the comment that generally came back was that everyone's doing an algorithm. You can throw multiple different algorithms and come up with an AUC. So, really what is so great about yours? And it took us quite a journey. And we were very lucky that the racing industry bought into the idea and invested money into the research, and clearly it demonstrated impact, and they continue to fund us. But then this actually then led to the Medical Research Council seeing, oh, okay, there's some truth to their work, and let's now start funding it.
Well, one question I do have is, you applied the methodology to the entire cycle, dividing in segments. But did you find that there was a segment who contained more, if you want, predictive information? I would expect that P-wave, but it is interesting that you utilize the entire cycle, and I just want to hear your comment on this issue.
Yes, so you're right. It's something that we are trying to identify. So with complexity analysis, when you use feature detection, what you do is that you input a parsing algorithm that detects multiple features over a cycle, okay? And then it gives you all these features. So it lists you about, I would say, close to 30 or to 40 different permutations of features that the parsing algorithm detects. Now, what we are trying to do, what is part of what is currently we're doing, is that we are trying to reverse engineer. What we're doing is that we are removing one feature. So it's like a leave out one feature and keep in the rest. So let's say we've got 40 features. We take one feature out and we keep 39, and then we run the algorithm again and see which of the one feature is the most important feature that gets us closer. Now that means, I think with 40 permutations, we would have close to over 900 to 1,000 over permutations that we will need to look at. So the postdoc is going through all that various permutations to try to reverse engineer and see whether we can identify a particular feature that is defining.
Thank you. Yeah, it's a very long work to perform.
Yes, yeah. Very interesting. I have one just, I feel like a linguistic purist, but is it correct to use atrial hypertrophy? This term, it is atrial dilatation. This is what I would recommend.
Okay, yeah, that's a fair comment as well, atrial dilatation. I guess that's a different. Sorry, go on, Gary.
So no, I was going to ask a question, but please finish.
No. So I guess I'm using hypertrophy in the loose, broad terminology of the enlargement of the atrial chamber.
Because atria, they do not hypertrophy. They can dilate, but the actually, I'm sorry to be such a purist, but it is dilatation, so I recommend to use it.
Okay.
Unless there is something special in the anatomy of the horse, I don't know of course.
Actually, I don't know, Emanuela, you were in Bratislava in 2014. There was our colleagues from Brazil, and they presented some study on horses. And during the evening, we were developing a discussion on the ECG, how to record, and what will be the ECG like in Centauri. Do you remember?
Actually, it is interesting what you are saying, because, of course, for example, artificial intelligence can detect the differences among species, probably.
Yes, yeah.
Yeah.
And Centaurus, it has horse body and a human torso. So, yeah, sorry.
Yeah,
I don't want to distract serious discussion.
No, it is interesting. I mean, it's really a new horizon if you want to look into.
Gary, you had a question.
Actually, on the study that we did on three-dimensional restitution analysis, so I see that we're actually predicting AF, but we're using ventricular parameters. So I don't know if any reviewers have commented on it. Have we ever tried using P-wave parameters and linked that?
No, it doesn't work. So we've tried using P-wave parameters and it doesn't work. And that is a question that reviewers have commented. And it is a subject of what there's an ongoing study in it. And I mean, we think we know what's happening. And it's so we have some data we hope to publish. And we suspect there's actually a molecular change occurring in the atria of at least of horses that have AF that allow them to resemble and demonstrate ventricular phenotypes as well. And that may suggest that switch as to why using even a ventricular pattern on ECG may help us identify an AF episode. And it is something that has come up and we're trying to investigate. We've got some evidence, but we don't know. We're exploring whether it's really just a lab error that we have, or is it really true?
Thank you for that. Is there any more questions from the audience for Kamalan?
Thank you.
Thanks very much. So can I now introduce the next speaker, who is Dr. Shreen Mohammed. So she's a cardiac electrophysiology fellow at Queen's University in Canada, and her talk is going to be on predicting heart failure from ECG recordings. Well, I was told that Shreen's actually not in the meeting. If that's the case, can I introduce Kiera Lieblik? She's also from Queen's University, and her talk is going to be on cybersecurity. Should we worry about it? Hi, Kiera.
Hello, let me just attempt to share my screen here. Oh, maybe not the whole thing, 1 second. I'm new to Teams. I'm normally a Zoom user. Are you all able to see my screen?
Yep.
Yes.
Wonderful. So I will be taking a little bit of a different route today and talking more broadly about cybersecurity and cardiac medical devices. So my name is Kiera Lieblik. I am a medical student studying at Queen's University in Canada. I've done some previous work with the ISE young community, and I also have a particular interest in using machine learning in resuscitation and acute cardiac setting, as well as patient and provider education on cybersecurity in medical devices. So though this may seem like something very abstract, like do people actually want to hack medical devices, it's actually becoming an increasing problem in this field. So we know that based on a recent analysis of over 300 million medical devices globally, that about 53% of devices are vulnerable to attack either through them not having enough built-in security or through not enough patient education around secure use of their devices. Some high-profile previous targets include insulin pumps and drug infusion pumps. So you may have seen, but in the Food and Drug Administration, so the FDA, which is a regulating body in the United States, there were over 10 recalls for updates on infusion pumps and insulin pumps over the past 3 years. And over 400,000 insulin pumps were actually recalled this year alone due to security issues and actually access to certain networks through hackers through these pumps. So additionally, there's actually growing concern in cardiology around cardiac implantable electronic devices and how they can be accessed and used maliciously. So why even hack a medical device? What is the actual use to somebody for doing that? The first is selling data and political gain. So we know that healthcare data can be used for certain population marketing, which is why some people buy this data, as well as in terms of political use. You can actually use this as a way to access someone's personal data generally within their healthcare, to access actual healthcare systems, sell that entirety of data, and actually to leverage for political gain. So there is growing concern around if someone can control someone's pacemaker, can they actually cause it to fail? Can they cause it to go into overdrive? And we're now seeing that this may be something we see in the future. There's also prestige around it. So within actual cyber communities and hacking communities, hacking into large networks actually builds credibility or prestige in those communities. There's also medical devices malfunctioning as a result of ransomware or other hacking of larger healthcare systems. So we've seen now a few cases where there's been investigations around patient deaths during larger hacks of medical systems because these devices rely on them working properly. And additionally, these devices may be used to actually get into larger medical and health systems. Additionally, there is a competitive market around these devices. So actually gaining insight into how the software works and reverse engineering it is a motivation for competing manufacturers to actually hack into these systems, as well as people who want to make off-label devices to sell. And then finally, to bypass costs. So again, develop our own devices, or develop their own devices, as well as to bypass costs associated with using these devices and using the associated softwares. There are a few key areas of vulnerability that people aren't necessarily aware of when they're using medical devices. The first is physical tampering. So actually being very aware of the fact that these devices can be compromised if anybody is able to access them before they're implanted. So they can actually be physically tampered with. Data can be taken for them even when they are then removed, just making sure that we have good stewardship of our resources and understand where our resources always are. So these devices can't be used maliciously. As well as broader network access. So as I said, when somebody accesses a healthcare system through ransomware, they can actually use that to then access devices and vice versa. And then finally, wireless communication. So these devices basically operate on certain frequencies when they communicate with someone's phone, for example, with a medical network, or with just generally with any like device recording system. And these frequencies, if they can be infiltrated, the device may actually think it's connecting to a healthcare network, but is actually connecting to somebody who's trying to maliciously access that data. And there are very direct patient implications of this. So for example, if these devices are compromised, even as a side effect of a network being compromised, this can impair data collection, this can cause failure, overdrive of pacing, and this can actually impact battery function. So there is a thought that there are a lot of devices that have already been accessed as a side effect of broader healthcare breaches, and just like that continuous access of them actually drains their battery quite quickly. So there are 4 main steps to basically prevent the access of healthcare data and malfunction of devices as a side effect of this. At the manufacturer level, these devices can be built in a way that's more tamper-proof. So there are now actually regulations around how tamper-proof a device has to be. So if someone can physically access it, are they able to actually break it open and manipulate it, as well as the networks that the data is stored on by the manufacturers, making sure that they're secure. And there's more and more popular now having people actually paid to try to infiltrate these networks in order to see where their vulnerabilities are, as well as making sure that the frequencies that these devices operate on are usually low, which actually makes it harder for people to infiltrate them. And then also to make sure that the data is scrambled and then unscrambled once it goes to the actual network. And then having actually security firewalls within the device. So when it's communicating, it can try to basically block any ransomware attacks. On the regulation front, I mentioned the FDA, but generally just government policy around regulating medical devices and making sure that they meet minimum standards. Also having documentation guiding different manufacturers and practitioners on best use of these devices and best development of them. So certain checkpoints that need to be met, as well as within industry having certain standards. So making sure that even internationally, there are standards around cybersecurity, and then making sure that the way they're used is also regulated. So hospitals having to have secure networks, practitioners having education around cybersecurity, et cetera. At the practitioner level, we really have a duty, I think, to stay on top of information around cybersecurity and medical devices, as well as on top of recalls and FDA recommendations for software updates. So for example, knowing, okay, I have 30 patients with these devices, and there's now a software update that's come out that significantly improves cybersecurity. How will I get these patients in my office? How will I make sure that their software is updated? As well as patient education. So telling your patients, hey, if you ever get any calls around your medical devices, asking you for information about them, etc., we will never do that, and you should never answer those, and you should let us know when this happens right away. You shouldn't open any emails around this. You shouldn't update your medical devices to your network or your cell phone when you're on a public Wi-Fi, for example. So just little best practices to give to patients, which leads to the patient level and following these best practices. I'm trying to be mindful about not leaving, so devices like insulin pumps that aren't necessarily always attached, not leaving them around, not plugging them into unknown devices, and making sure to also be an advocate for your own healthcare and always asking clinicians around cybersecurity when using devices that do connect to internet. So overall, data sharing technology is a key growth area in a healthcare setting, and it's critical that manufacturers, policymakers, healthcare practitioners, and patients really collaborate to mitigate risk. And I think it's important to continue to raise awareness around this, because I think it's an area that's not very well known, and people might not always think applies to them, like, oh, well, this is the manufacturer's responsibility, when in fact at the practitioner level, we actually do have ways that we can mitigate risk for patients. Which is what I leave you with, which is to consider what your role is in keeping patient data safe specifically, and how you can help in prevention of loss of data, and also the danger that patients can be in when their devices are compromised. So a little bit of a different talk, but I appreciate your time and open this up to any questions.
Thank you, Kiera, for this interesting presentation, also providing hints on how to discover and how to avoid these kind of problems. Yeah. Actually, I think we are in a very difficult balance nowadays between security and, if you want, openness, and because that is also a very complex problem, to assure that accessibility is also possible without too much difficulties, because many people found difficult to access the information. In my country, for example, there was a big debate about this in terms of really the possibility to assure accessibility, particularly to older people that may not be so familiar with the use of ID computers. So I think we are in a very, if you want, complex moment in that regard, because we need to make things simple and easy, and then on the other side we have to assure safety.
Absolutely. I think there's a very important balance between letting patients have access to their own healthcare information, making sure that they understand what that information means as well. So they're not saying, oh, well, my blood level of XYZ is increased. What does that mean? Additionally, then understanding that as soon as we give public access to data, whether it's on paper or through the internet, we're now increasing places where that data is and where people can access it. I don't think that there's always enough of an understanding of, it may seem benign that someone has access to your blood work, but it's more that it's a gateway into the rest of your information as well, and that people really can leverage that, and that it may sound kind of like a crime show and we're like, oh, people could maliciously turn off medical devices, but this is in fact something that is a possibility. So we have to be vigilant about it.
And also on the side of the institution, it was, I mean, in Europe, it is a very complex problem in relation to the new European regulation for privacy. Mm-hmm. So for example, in home monitoring systems, we had a major issue on the fact that some of the database for implantable devices databases was in fact abroad in United States, and this is part of the problem because it's not allowed by the European regulation system. The database patient database should be in fact settled abroad. So eventually we were able to overcome this issue because the lawyer of our hospital came to the conclusion that indeed that was in the main interest of patients. So we would be able to continue to proceed in home monitoring despite this limitation because of patient superior interest, if you want. But that was a very hard decision they had to take in somebody taking the responsibility. So I think that it seemed to be something like boring or too complicated, but it's really part of our daily life, this constraint about privacy issues and safety issues.
Absolutely. And as you highlighted, it really, the regulations vary from region to region. So let's say you have a device that's developed, as you said, in the United States and now distributed to all of these different countries. Now does how that device operates and where data is stored have to be altered from country to country? And will we see that in countries where maybe there's like low to middle income countries, that there's less ability to create these security checkpoints and more vulnerability to ransomware in hospitals, et cetera? So there's also a socio-demographic component to it.
How far is this problem perceived by patients? Do they see it like a problem or just do not know about these possibilities? Or I don't know. I
don't think patients are really counseled on cybersecurity. Yeah. And I think it is a problem. I think there's this perception of, oh, well, we don't want to scare patients out of using these devices. Yes, yeah. But I think to introduce it more as like everything has risk, every medical procedure, these devices are very safe and the likelihood of something happening are very low, but there are ways that you can make it even less likely. So maybe not introducing it as a, oh, this is something you should be terrified of, but this is something where there's a very low possibility, but there are some things you can do to make it even lower possibility. And generally just, I think, counseling patients on being mindful of no one's going to ask you for your health information over the phone or over email. We're only going to ask you in person. And that's something that a recommendation for all patients, regardless of whether or not they have devices.
Okay, so probably their main concern would be the malfunction. The other concerns are like, well, not of no importance, but anyway, the malfunction, I think that for a personal perception must be very strong. Thank you.
Thank you.
There was actually one point that Natasja wanted to raise. She unfortunately couldn't make the meeting, so I put it in the chat, but I'll rehearse it here. So it says in the guidelines, randomized controlled trials are regarded as the gold standard. Does this have to change with the rise of AI in healthcare studies? It's open for discussion.
Yeah, I think that's an interesting question. Yeah, do you mean like, should AI be the gold standard for predictive data analysis?
Yeah, or that can we change the study type? So, for example, in terms of the evidence hierarchy, RCTs are typically at the top, or meta-analysis of RCTs. If we introduce AI to cohort studies analyses, would then they be at least equivalent to RCTs in that regard?
I think so. And I think, that's always, we have this data hierarchy, right? But realistically, you have studies, like different types of studies that are more significant based on sample size. Like if you have an RCT that has 10 participants versus an observational study with AI that looks at 2,000 participants, I think then you have to start to look at case by case. But I think that absolutely, if you have cohort data for 10,000 patients over 10 years and you apply machine learning analysis to that, like that is incredibly strong data association, and it's like multivariate analysis as well. If anything, I think that we might see in the future that becomes the gold standard and really is above RCTs, because that realistically RCTs are also limited in that they're mostly looking at medical intervention and don't always give us information about risk, right?
Definitely agree with you. RCTs are not everything. But, are there any more comments from the panel?
No, thank you.
Well,
okay.
If I can make a comment in general, I think that this session, I'm just sorry that we couldn't hear about prediction of heart failure, because I would be really But I think we were lucky enough because, in fact, we heard some part of this also from Deepak. Actually, was his presentation covered part of this field. So it would be very interesting maybe to prepare like a document or a review on together this panel that we might submit to the journal of. I think it is a very, very interesting subject with the, and would be very interesting to make the point with you on the issues that we cover today. So maybe, Gary, maybe you can propose this officially, and we could work on a paper on the subject. Don't you think it would be an extremely timely and we have all the materials gathered? So, I mean, there was already a lot of information in the presentation. So I think it would be a very welcome initiative.
Yes, that's an amazing idea. So I'll put this to Bulent actually, and I'm sure he'll be very pleased that we're all very keen to pursue this project. So
would be a very interesting document, making the points. Maybe also we could also make a point on the different methodology, because there is a lot of confusion even in terminology, if you want, neural networking and artificial intelligence, deep learning. So I mean there is a lot of points to be made. So I think that could be a very interesting panel working together on a project like that, if you want. I would be very, very interested, and I hope Gary too, and Ljuba too, also to.
Absolutely. Yeah.
Yes, it's amazing. We've got a wide range of expertise. We've got data scientists, we've got vets, we got medics, and we've got scientists and engineers as well. So I think it'd be amazing to bring together all of the expertise and all of our experience into producing this document. I'll definitely raise this with Bulent after the meeting.
Great.
Yeah. Okay. And before we shall say goodbye to each other, I would like to thank you, Gary, for organizing this meeting and all these young investigators, because it was a great idea. And since we are working on online presentations for 2 years, we are sufficiently skilled already. So at the beginning, it was sort of disaster. So thank you very much for this. I appreciate it very much. I'm sorry I was not able to participate in the previous, but I managed to participate in this session. So thank you.
Yes, thank you, Gary. That was really wonderful what you did. Organizing all this, putting together, and I think it is the right way to go. I mean, it's, of course, I think that the result, I mean, the net result is quite striking.